I welcome you all to the panel of community mental health. Now, for those who are new to the concept of community models, it's primarily a much more decentralized form of psychiatry, psychology in practice per se. And it perhaps looks into the role of each member within the community as a stakeholder in the process of healing of the individual. So in a country like India, where we have the professional patient ratio of about 0.75 for a lakh mental health seekers, something like a community-based model of mental health seems much more feasible option, at least to reach out to the masses. However, we are still kind of navigating through the course of designing such models in most of the parts. And thus we have Riya Biswas and Dr. Manoj here, who will be enlightening us about their respective models of functioning and how perhaps we could look forward to such pathways in a city like Delhi also, right? So, sir, I would like you to start and talk about your model. Dr. Manoj Kumar here is also my professor. He was the director of, he is still the director of Mental Health Action Trust. And during our master's, Mental Health Action Trust had a collaborative program with Tata Institute of Social Sciences. And they were running the fieldwork course for this MA specialty in clinical psychology. So, Dr. Manoj Kumar. The slides, sir. It'll come both the sides. Would you want to stand here? Is it visible?
So, good afternoon, good evening to all the survivors who have survived the morning sessions and the afternoon session and are still here. Thank you, first of all, for being here. In a way, as I was listening to the earlier sessions, I felt that this was in my opinion, from my own reasons, this was a good time to talk to you, because I can recognize all the sessions that I have sat in, all the different threads are all completely relevant. I was very happy to listen to many of the presentations and discussions. And in a way, what I'll be trying to do in as short a time as possible is to suggest that all these need to be integrated. That's the only thing that I would want to suggest to you. So my background is as a medical professional, psychiatrist, and it would be safe to say that the journey has been one from the brain to the society through individual psychology. The last discussion, Dr. Sen, Dr. Chatterjee, and the other panelist very interestingly spoke of 3 different aspects: the brain, the systems, the educational systems, and what needs to change, and the individual who needs to change. And that is really what where we are at in terms of the work we do in Kerala. It's a community mental health model that we are involved in delivering for the last 14 years. And we have more than 60 centers across the state, and we're slowly spreading to other states also. We are in Himachal Pradesh to start with, and we would welcome an opportunity to work anywhere in India. So next slide, please. Yeah, so this whole conference is about the unspoken issue of mental health in our societies. And in urban centers like here, with so much of young people and organizations working, it's really gratifying that we are now really discussing, we are acknowledging the presence of the elephant in the room. Next slide, please. And really, there is enough and more evidence that a huge problem exists. But whatever the amount of evidence is there, as evidenced in all these conversations today, things don't seem to change very much or don't seem to change at all. Tomorrow is the World Mental Health Day, and every year, as the World Mental Health Day draws, there's a lot of discussion, but does anything much change on the field? The remit I had for today mentioned young people in distress and the positive fact that more and more people are open to seek help for distress. But what happens when you seek help? The illustrative example of the school counselor, I could very much resonate with, because that is what happens in Kerala too. Hardly any child feels confident, comfortable enough to go to a counselor. So even in urban places like Delhi, how many of you, A, are able to access good quality care, B, be able to afford it, and C, able to benefit from it? And I guess the answer would be no for most cases. So imagine the population that I work with, which is entirely from the lowest socioeconomic strata, and in rural or semi-rural areas, even in a better resourced state like Kerala, the situation is dire. So what do we do? Can I have the next slide, please? So what we do is also at the moment quite fragmentary. I'm sorry to continue with the elephant analogy, but in reality, we are all in places like this conference. We all have a solution, but it's all disparate, and it's never seems to come together. Next slide, please. A lot of confusion exists even at the level of terminology. What are we really talking about, and how different are different concepts? Are we as a psychiatrist, my first point of reference is, are we speaking about people who are reasonably, shall we say, healthy, or having some problems but by and large healthy, or are we talking about people from a medical perspective who are ill? Now I'll explain. In the medical perspective, we define illnesses based on how much it affects our life. So a problem becomes an illness when it significantly affects our life. And that is how we make a distinction between different issues, different problems and disorders. And these are not watertight compartments. It's on a spectrum with interrelationship between all kinds of issues. And the real challenge when you work in the community is one of who makes these distinctions. When we talk of well-being, when we talk of normal mental health, when we talk of enhancing our capabilities, are we talking about the same issues which are relevant in mental disorders? Usually no. The factors which affect our normal health and the factors which affect our illnesses are different, both for physical disorders as well as for mental disorders. So the confusion starts with offering solutions which are either tailored for health or are tailored for disorders, and a lot of confusion about who needs what. So for example, what I would propose is that it's all complementary. So psychotherapy or counseling is not a substitute for medication, nor is medication a substitute for anything else. Things which keep us healthy are necessary before we fall ill. But once we fall ill, the same things may not work, because we are working from a deficit state, and what is required to bring us to a normal state will be different. So all approaches work, and depending on, somebody was in the morning talking about Osho's approaches, which is not single but tailored for people, and that is very, very true. When we talk of mental health also, we cannot talk in generalities. It needs to be tailored to individuals and tailored to situations, depending on the huge number of ways of healing that there are. So all of these have their own roles, but I would suggest to say are complementary, not substitutes for each other. Next slide, please. Yeah, so in our experience, the model which seems to work well is when we combine all these aspects. What works at the population level, what works in institutions such as schools, and what works at the individual level. And the only difference that we propose is that all are available at the same time. For example, there's no point in holding a conference or having mental health literacy or awareness creation if that the people who thus become mental health literate do not have any space to turn to. So we do require spaces, we do require mainstreaming discussions on mental health, but our suggestion is that unless it is combined with availability of services, then the same piecemeal compartmentalized approach will continue and will not lead too much. So what is often not talked about in this debate, maybe not so relevant in literate middle class urban settings, is the impact of social determinants on mental health. For decades we have known, and that's another elephant in the room, which is that we know that mental illnesses and mental health problems are much more common in people who are socially deprived. So unless we attempt to remove the social determinants of mental health in communities, there is no point in thinking of individual or systemic efforts to help someone after they have developed problems. So primary prevention is when we act at the community level. It could be individually, psychologically, at the group level, at the family level. It could be from the perspective of increasing resilience, or it could be from the perspective of poverty elimination, women's empowerment, and so on. Unless all these primary preventive measures, including psychological, are matched with good services that people can afford, there's not much progress that we are going to make. And those systemic changes may be at the governmental level, at the macro level. We talked about the educational policies, or it could be at the individual level, like in schools that Prakriti that was set up. Next slide, please. So, good care is integrated with promotion of health is the need for the outcome. Until we have such services based in the community, owned by the community and led by the community, not just located there and involving local communities. That is what we require. And it needs to be integrated with all the other systems, with physical healthcare systems, with the educational systems and all, and not just focused on individuals, but families also. Next slide, please. So can we do it? Ours is an experiment in trying to see if it can be done. We work in a very much prevention-focused model. Our starting point, no longer. We started with individual ill people as a starting point. Now our starting point are communities, with both ill as well as healthy people. We work within the schools of those communities, with the women's groups. We look at livelihood generation. We look at employment, upskilling people who have basic education, and so on and so forth. And in parallel, we offer a service to people who need it, both at the individual level as well as at the family level. How do we do it? We are able to do it because it is entirely decentralized, and as I mentioned earlier, community owned and led. And it is as demedicalized as possible. The role of the psychiatrist is crucial, but not in the way that it is being currently practiced. Psychiatrists' roles need to be rethought, re-looked at, and a lot of the care is much more important than the medicines. And that care can be provided by lots of people, including non-professional mental health workers. There is enough evidence now from India as well that you don't need to be a psychologist or social worker or a psychiatrist to provide mental health care, provided there are systems of supervision and support. So our core team comprises of non-professional mental health workers, and outside we work with thousands of volunteers in delivering good quality care. And in the process, especially after the onset of the COVID, we use video technology and other aspects of technology a lot. So I leave you with that one suggestion or one opinion, which is that it is high time we started working together. We work in silos. Each of us have our hands full, so that we are entirely preoccupied with our own ideas. But we need to work across sectors. We need to work together, and we need to see that there are good quality services available for people who need it, and not just us doing individually. The collective, the gestalt will be much more effective. So thank you for patient listening. Happy to take questions at the end.
Thank you, Manoj sir, for that brief introduction. Just to give our dear audience a little bit into a small picture of the scale of work that he has just briefed up about. When we were working with Mental Health Action Trust, we were working in a community where we had one psychiatrist, couple of psychologists, maybe about 10, 12 of them, and about 100 volunteers at that point in the form of community social workers, and maybe hundreds of case managers catering to the needs of 3,500 population. And this stemming from the most lowest strata of the society. And when, in a lot of our elite circles, the concept of the lowest strata is also very subjective. Over here, we're talking about people who are completely below the poverty line, who are not even familiar with the regional language of Malayalam, forget English or Hindi. So often enough, they need translators who are coming with them and helping with the language functioning. But nevertheless, we had back then about 3,500 patients who were seeking mental health services through this particular model with just one psychiatrist in the picture. So that is the effect of a community-based model, perhaps. Yeah. Very closely related is Riya's work. And before introducing Riya, I think the first thing that comes to our mind is about yesterday's PrideX panel, if you guys were here, where we had Abhishek, Anika, and Shivanki, Vikram, and Divya talk about how most of the times mental health services are not reaching the people within the margins. They're so much marginalized that mental health services for someone with disability, someone from the queer spectrum, someone who is coming from the lower caste of society, are they really getting the required mental health support in that particular sense? So Riya is here about to talk about her work with Mantavya and her own personal experience in that journey. So over to you, Riya.
Thank you, Reshma. So my mental, I'll start with a question. I want to start with a question because most of the things I think got covered. I won't repeat it. So what comes to your mind when you hear this word, mental health? Is it not working? Is it good now? A little more. Fine. Is it working now? Okay. So I was asking, like, what comes to your mind when you hear this word, like mental health? Any one or two word, like, can you share? Okay, one more.
Suffering from your own,
Okay.
like suffering from your own thoughts and terminologies.
Thank you. So I just like, why I'm talking about this question particularly. It's mental health generally, whenever you hear this word, like I nowadays as well, like we say that the one thing would immediately come is depression, sadness or stress, and it has been looking at as you quote that deficit based model. We've been looking the mental health, कुछ खराब है उसको ठीक करना है, looking at this, but we as in Mantavya are trying to build that or work on that strength based model looking mental health as in a strength-based model, because mental health is not that the person who has depression has it, but we all have it, whether we have the illness or not. So I want to bring in, like, first my journey and my story, like how Mantavya came into the picture first. So when so I'll share that it was somewhere 2008, in my 12th grade, when I first attempted to suicide, and my family rescued me. And I remember the day when I was discharging from the hospital, the doctor saying that I'm doing all right, but my parents need to bring me to the hospital again for the counseling. And my mother said yes. We went back home. We never came back to the hospital again. I come from a background. My parents, like, they are. We come from a middle class family, and where we are, it's like they are struggling already, to make the survival and all. They don't want to get into the counseling thing. In 2008, like, nobody's talking about, and I for the very first time heard the word counseling. I came back home. My mother said, like, oh, I'm doing okay, there's no complication in my body, good to go back to the school. I started, and then again, I in my first year, second year was going all good. I had whenever things used to go down and all those things, I used to have a lot of I didn't know how to manage my emotions. I used to have lots and lots of negative emotions, and that's how that thing happened to me. But now I have tried and now I can't die also. That one option just gone, so I have to live. So I was just finding the ways how to live. um, and then so on, I was doing job and everything, and then there comes a point in 2016 when I again, like, I didn't know how to go ahead with my in a romantic relationship where I was really, I was like 6-7 years relationship was touring apart, and then I could not pass my CA final, and I was like, oh, what I'm doing in my life, I'm 26 and nothing is working for me, let's die again. But again, then I have to pull myself back. Oh, this can't happen because I have tried. Sabne data tha. Everyone, you just said, like, you can't do this, just think positive, just think positive. But I could not. I mean, I don't know how to think positive. I don't know how to not think about that person or my marks or think that I'm a failure who can't do anything in a good way. But the thing is, when you don't have anything, like, particularly, there's something in me, I think there was that which I called that strength-based system I'm quoting. So I'm think, and I believe, and then Mantavya also believe, that we all have a strength within to cure ourselves physically and mentally as well. Like, the health, when we talk about, it's not the physical health but the mental health also. So I thought that I normally don't take a lot of medication for my physical health. I thought that there's something can be done with the mental, like with my mind. What is wrong with my mind? Most of the people would say that there's something wrong, think positive. So I started then coming and searching and reading about it. What happens to me, why I'm different, why everyone else in my life, my friends of my age, 26, they are doing great job and doing great things, and why I'm not able to do that. I read a lot about it. I started doing, started with doing little changes. There's the big change, I would say, happened in 2017, where I just was sitting just online and, found someone stranger and started talking to them. I shared my story, that what I was going through, to someone's article I read, and just shared what I was going through. And suddenly, somebody who's doing great in life, she said that she has gone through the same, and she is taking therapy from the past 2 years. And it was so I'm like, for a failure person, it's okay to think this way, but somebody who is an author, how can she thinks like, how is she taking therapy, why she has to take therapy, and then I had, like, she gave me the time, and we had really 3 hours conversation. I came back home, and suddenly I felt good. I don't know for what reason, like, I felt good. And I just was wondering what happened in this conversation, which has not happened with me in this 27 years. And that was, there was no judgment, there was empathy, there was relatability. There was looking that, oh, if that person can live their life, I can also. And I thought, like, why don't I, or why don't I have a space where why don't we have a space where, maybe most of my friends are feeling this way. They want to find the right way. Maybe my family, maybe my mother, or people around me are looking for this space. That's how the empathy circle came into the existence. We called, like, 10 people came. I just wanted a space where we listen to each other without judgment. The only rule we had, like, we will be here talking, sharing whatever alive in your life, whatever the struggle you're going through. Just talk about it, and what we are going to do, we are going to just listen. Koi protocol nahi, kuch nahi. We listen, and after that, an hour or two, most of the people felt so good, and telling that, we don't find this space in our, normally in our life. And this is how the journey began. I won't say that I was completely healed by that 2 years when I worked on myself, but somewhere I was not having that societal thoughts. Also, by this time I also had this anxiety disorder. I developed it so much that it was showing in my body. I 6 months again, went to a lot of doctors, hospitals, and they were doing all the tests of my, there's some congestion in my chest or somewhere, and then they were like, found nothing. And I came across somebody said that, there's something in your mind. And again, I'm like, what wrong in my mind? So I started learning about, and I think I would say that that experiment happened in me. I started doing that experiment on me. With that, I found that that empathy circle was doing a great job. People coming, listening to the story. But there's one more thing coming, that most of the people who are coming either had some therapy or taking, or illnesses. They know about mental health. I'm like, where are the other people, who doesn't have the mental illnesses? Kahan ja rahe hain? Unki mental health kahan hai? Then I just I had few conversation with my friends. Some of the people would come and say, oh, I don't need that space, because these space are for the people who need empathy, क्योंकि उनको तो आता नहीं है, वो ज़्यादा emotional है, and they feel like crying and all those things. And then I just thought there is no awareness. I found that there is, most of the people know, but I found in my experience, I also Googled mental health when I was depressed, when I did attempted suicide and all those things. Why aren't we doing that? This question came to me, that why aren't we doing something when we are okay? So sort of saying that, okay, not having an illness, taking care of what we have. It's a gap. Complete a gap when we are doing okay, and how we are not talking about the mental health the much, we are talking about the physical health. जिम जाते हैं, योगा करते हैं, बहुत सारी चीज़ें वी बीन डूइंग टू कीप आवर सेल्फ फिजिकली हेल्दी. आर वी डूइंग दैट टू बी मेंटली fit? So with that idea, to bring that awareness, Mantavya started. We've been working in Mantavya, looking at the strength which I found within me, and I feel that we need, like, we need the counseling, we need the the other medication for sure, for the cure, but there is something in us. We have the strength to take care of ourselves. And me, whenever I think of myself, that what if what it would be have been a really great loss if my family would have not helped me or rescued me that day. I feel so grateful, and I really don't want this to happen to anyone, like, and how we take care of, and how we create or tell those tools, make the people understand that, oh, how do I regulate my emotion, whatever I learned from the people around me, or myself. How do we create those systems, so in whatever the workshops and the spaces we hold in Mantavya, the one thing we believe in, we don't give them a single story or a single fit box to, these are the 4 things you should do and you will be great. We help them to find out what works for them, what works for me. So they come to this, and now, because I come from a background where I think counseling or ye sab shabd nahi sune the, so I also, we as in our organization as well now, trying to go to those spaces as well. We have started working in the communities, the slums nearby, where we work with adolescents, children, and then telling them from the very early age that they know when something is going wrong, when to go and seek for help. And the other marginalized section of our community, like the cure community, or the women per se, and whoever gets affected more with the setup like we have. So yeah, so we've been working with this idea, and I again would like to just complete it with this, that uh, the the thing will change, will have, but the awareness is needed, and we all have the strength to take care of ourselves and the people around us, plus the professional help needed, but it can't help us unless we help ourselves, and the people around us help us also. Yeah, so thank you so much.
Thank you, Riya, for sharing that. You have raised perhaps 2 very important questions of, number one, agency of the help seeker, and secondly, the social structures within which we are operating. So I remember even with our working with MHAT, this one time when we went to the field, most of the mental health setups were placed within palliative care centers in Kerala. And this one of the volunteers of a palliative care center was explaining to us about how, while setting up their palliative care center, they made sure that it's besides a mosque. And the idea was that, psychiatric resort, mental professional resort is going to be the last step in seeking help when it comes to the community. The first resort is going to be the religious route. If it doesn't work, then some more cultural practices. And when nothing else works, they might turn towards mental health professionals. So I think a beautiful way of integrating an individual's own choices along with community mental health was something that proved successful in such treatments and bridging the gap in that particular sense. And that actually raises an important question about how we need to move beyond a medical model of understanding to a social model. where community members themselves are coming together, understanding the social structures and trying to fill up the gap, right? So both of you operate in different locations within the Indian understanding. So how do you understand the treatment gap in your location base versus in Kerala? And what is the complacency to mental health care?
Thank you for the question. So from the last 3-4 years, like, I've been working on this. So the one thing I've seen that because Delhi is a city, and where most of the people knowing and at least know that this what is mental health particularly, and uh, here also, don't leave that question, or there's the taboo is not that much that they don't talk, or they talk about it. The only, I mean, the main gap I see that to come to its point to accept that that it's me, or it's happening to us, uh, or whenever the things comes up, I have been looking at the things where again that because things are accessible here, like people know the resources, like we can go to the therapist and all. Many of the time this also happens that the setup which is around us, which we can go, and as you said, that the first step and the people around us, we sometimes don't access it. We tend to just go and for the seek for the professional help first. uh, and it's again like the thing where we are talking that, oh, it's okay to take therapy, and again we are saying like, oh, when is the time to take the therapy, when is the right time to do, am I actually accessing the resources around me, or am going uh, it happened like a day or two, I'll tell you that many of the people comes and tell us that they've been taking therapy for the 6 years, 6 year, and so on, like, and how these things also create another narrative that, am I doing, like, working the accessing the people around me, or taking the therapy as in my just going, getting the things know, and then coming back, am I doing something about it or not? So I think that gap I'm seeing, and it is, I'm talking about the people from who have the affordability and can go. I'm talking about them, but I have also worked with the slum, and I have also come from a from the middle class there, where we have not heard about all these things. We don't see that value in it. Value in the sense I'm saying, because not having the resources again. Then when I'm saying that some people, the state, the community, that larger people can go and that access that, but there are people who can't, so they don't look at it. प्रॉब्लम है ही नहीं, मतलब अगर होगी फाइंड आउट करेंगे तो जाना पड़ेगा to seek the problem. So it doesn't it's not there. So I think that like again it's like दोनों ही चीज़ें देखी जाती हैं और अलग अलग तरीके में. I live in South Delhi, अभी मैं यहाँ पर रह रही हूँ जहाँ पर there's like the area where the CR Park and all the people lives, and there's the Govindpuri and then the slum there. I can see that, and the idea is really different. And what I'm sharing with you, it is that, like, that the narrative, the both of the narrative is somewhere again coming to the failure of taking the professional help, or also not taking it. Again, then goes to how we are building that that the community support and the inside work or the strength we talk about. Yeah. Thank you.
I remember so talking in the class also about it, about how unlike physical illnesses, in the case of mental illnesses, patients don't really feel the need to complete the course of the medication because there's no visible change. So is there a need to continue with the medication, paying such high cost for the medicines? So might as well find an easier mode of healing, right? So if you could just want to enlighten us.
Yeah, see, apart from all the other problems, there are a lot of systemic issues in the way modern psychiatry is practiced. The underlying basis for the practice of modern psychiatry is a deep understanding of the individual, a proper initial assessment which studies the individual as an individual and as a member of the family and society in depth. Now, it goes without saying that that requires time, so we normally take at least an hour to try to begin to understand a person and their problems. And the first problem with the way psychiatry is practiced is that it is practiced like it is practiced for for a common cold or cough. You get 3 minutes, 5 minutes with a psychiatrist, and they are supposed to be able to make an assessment and prescribe a course of action. I don't know how people do that, but they do. So it is of no surprise that in such a situation, the medicines that are prescribed, A, it may not be medicines that are required. B, the choice of medicines, the number of medicines are all not optimal. And B, and C, these are all medications are all which causes side effects unless you are aware of it and you have a system of preventing it. For example, we have a system where every individual that comes under our care is allocated a volunteer who looks after all these aspects, and we have time. It's constant monitoring. So we have systems in place which to a large extent mitigate the failings of the modern medical or modern psychiatric system. So when you practice psychiatry without a safety network, such as what we have, where we have families involved, volunteers involved, we spend time with people, we are interested in their welfare, in the longer term welfare, we follow people up. In the absence of all of that, if it is reduced to just prescribing medicines, then obviously it happens because there are side effects. People don't understand the context, and initially it may be ineffective. Often, even with long years of experience, I have difficulty in understanding a person with initially just one. It may take several assessments, several episodes of contacts before you come to know the complex human being in front of you. And that understanding based care package, which may include all the things that we have discussed, when the person is not so unwell, then it is important to build their agency and empower them to deal with their problems better. But there will be a time when they do require medications. There will be the care component, the support systems, like you said, your parents, family. All of these are important, and how do we provide all of these? That is the key to the success of the interventions. And imagine the current scenario where instead of all these, they're just given a long list of medications. So it's no wonder that people become disillusioned, become confused. And the level of stigma remains more or less unchanged because they're not seeing evidence of any change with the prescribed systems, not just medicines but counseling and so on. People flit from one counselor to another, not really getting the benefit that they were looking forward, and ultimately drop out. And the assumption is that this is a situation, these are problems for which there are no cure, and therefore to be hidden. In the social classes that we work with, overcrowding and poverty and all make it impossible to hide problems, whereas in our urban middle class or upper middle class settings, we try to hide problems because of we realize that this is something for which there is no answer. In recent memory, we had the HIV AIDS epidemic. Most of you were probably not born after that, but at that time when I used to work in that, and the stigma was huge because there was no treatment for AIDS. Few years later, along came treatment, and even better treatment, so that the stigma associated with AIDS is much less now. We hardly talk about AIDS anymore. It has become like tuberculosis, a chronic infection which can be cured with medication. Now, the stigma in psychiatry persists because all these interventions that we provide are given piecemeal and therefore ineffective. And therefore, we continue to harbor beliefs and, let alone, the middle classes. Every class of the society, it's the same level of stigma, same level of misunderstanding, and all of it goes down to lack of experience of good services. Not just an individual, but as a society, if we experience good mental health services, then I feel stigma will be less. And that's been so in our experience also. Thank you.
Thank you so much, Riya and Dr. Manoj Kumar, for this amazing session. In case the audience feel the need to connect with them, you can take their email IDs and write to them. Thank you so much.